Good day. I am Dr. Paul Siopongco. I am a retina specialist who is currently practicing in Metro Manila. I have been invited by the Central Visayas Society of Ophthalmology and the Southwest Mindanao Society of Ophthalmology to talk about diabetic macular edema with some updates on DME and cataract in tonight's PAO LEAP session. Before we start, here is my financial disclosure. The outline of tonight's lecture is as follows. Diabetic macular edema commonly leads to impairment of visual acuity in patients with non-proliferative diabetic retinopathy and is more prevalent in patients with type 2 diabetes than in type 1, accounting to nearly 12.9% and 7.86% of cases, respectively. It is the most common cause of vision loss in diabetic patients. The causes of DME are multifactorial. However, the predominant reason is attributable to the blood-retina barrier breakdown that leads to swelling in the hemless layer of the macula. It is important to note also that the results of the Wisconsin epidemiologic study demonstrated that the incidence of DME in diabetic patients in a 10-year period was 20.1% in younger onset group, 25.4% in older onset group that are taking insulin, and 13.9% in the older onset group that are not taking insulin. Chronic hyperglycemia-related accumulation of advanced glycated end products disrupts the blood-retina barrier characterized by endothelial cell junction breakdown and pericyte loss. The inner blood-retina barrier is composed of the endothelial cells in the retinal capillaries, while the outer is composed of the retinal pigment epithelium. Altered blood-retina barrier leads to interstitial fluid accumulation within and underneath the retina through leakage of molecules dependent on intact cell-to-cell junctions, as seen in this figure here. Evidence also shows that DME has an inflammatory component to the disease, with several chemokines and cytokines involved in its development. Upregulation of multiple pathways lead to increased inflammation, oxidative stress, and vascular dysfunction. There are also significant changes in the neurovascular unit, altering the homeostasis between astrocytes, ganglion cells, Mueller cells, and the retinal vascular endothelial cells. Retinal vascular permeability changes involved in the kallikrein-kinin system, which induces vasorelaxation via bradykinin and nitric oxide. DME can develop at any stage of diabetic retinopathy, from mild NPDR all the way to proliferative retinopathy stage, but it is more frequent as the severity of diabetic retinopathy increases. DME threatening or at the fovea is more likely to result in blurred vision and metamorphopsia. When the DME involves or threatens the fovea, the risk of moderate vision loss, which is defined by the ETDRS as a 3-line or more decrease in visual acuity, equivalent to a doubling of the visual angle, over 3 years, was 24% without treatment. The disease course is variable, with some eyes having chronic persistent DME spanning several years, while there are others who have rapid spontaneous resolution, although in these cases, the risk of recurrence is always present. The risk factors for DME and diabetic retinopathy are similar. These risks include the longer duration of diabetes, poor control of blood sugar and HbA1c, hypertension, and hyperlipidemia. Primary prevention of DME involves intensive control of sugar, of blood pressure, of blood lipids, and other systemic factors. At present, the use of anti-VEGF injections for the prevention of centrally involving DME is still not the standard of care. Let us now move on to diagnosis. Like any other diseases or conditions, history is important in the diagnosis of DME. DME is suspected in patients with any level of DR or diabetic retinopathy who presents with blurred vision and metamorphopsia. A detailed history including approximate date of the onset of diabetes, the use of insulin versus oral anti-hyperglycemic agents, and the quality of metabolic control should be elicited. Any associated medical problems such as hypertension, hypercholesterolemia, renal disease, and thyroid disease should be identified, along with thorough review of medications. It should be noted that mild to extensive DME may present without symptoms evident to the patient. During ophthalmologic examination, patients should undergo careful and detailed slit lamp and indirect ophthalmoscopic examination. Historically, DME classifications were based on the ETDRS definition of clinically significant macular edema, the criteria of which is presented in this slide. CSME, as defined by the ETDRS in the 1980s, is a clinical diagnosis made by slit lamp examination using a contact lens. While clinical examinations remain essential in the full evaluation of DME, optical coherence tomography is now routinely used to complement physical examination in the diagnosis of diabetic macular edema. OCT within recent years has quickly become an important ancillary procedure in the diagnosis and treatment of DME. In this photo, 3 structural changes can be seen. 1 is the retinal thickening as indicated by the yellow bar. 2 is presence of cystoid macular edema as pointed by the blue arrow. And 3, subretinal fluid as indicated by the red arrow. Macular scans can quickly and accurately identify even subtle areas of thickening along with quantitative metrics for different areas. Changes in the anatomic distribution of DME can be monitored over time, especially the fluid's relationship with the fovea. This information has proven crucial regarding the clinical and research implication for the evaluation and management of DME. More recently, the International Council of Ophthalmology Guidelines for Diabetic Eye Care in 2018 have adopted a clinical entity known as the Center Involving Diabetic Macular Edema versus the Non-Center Involving Diabetic Macular Edema for the evaluation of macular fluid. The classification is as follows. Center-involved DME has retinal thickening in the macula that involves the central subfield zone, which is about 1 millimeter in diameter, while all the rest will be classified as non-center involved DME. The image is a montage of center involving and non-center involving DME, with the row above showing a non-center involving DME, which shows retinal thickening that doesn't involve the central 1 millimeter zone, while the row below shows the opposite. The standard ETDRS subfields divides the macula into central subfield or foveal, the inner macula, and the outer macula with the following diameters. Moreover, OCT is a more sensitive method for objective evaluation of vitreomacular interface abnormalities, which include VMA, VMT, and ERM. Identifying vitreomacular interface abnormalities is crucial when diagnosing the etiology of macular edema, whether it is primarily that from DME or secondary causes of vitreomacular interface abnormalities or combined mechanisms. Let us now go to OCT biomarkers for DME. Diabetic macular edema's different OCT features have been associated with disparate prognostic outcomes and treatment responses. These biomarkers are as follows: the disorganization of the retinal inner layers or DRIL, external limiting membrane and ellipsoid zone disruption, and the association with vitreomacular interface abnormalities. But before we move to the OCT biomarkers, it is important to revisit what a normal OCT looks like in the observable anatomic layers. For the purposes of our discussion, when evaluating for DRIL, it is important to look in the demarcation layers between the ganglion cell layer and the outer nuclear layer, and in this photo, that's everything above the red line. On the other hand, for evaluating abnormalities in the ELM and the ellipsoid zone, we must zoom in into the outer layers, where we see 4 hyperreflective bands representing the external limiting membrane, the ellipsoid zone, the interdigitation zone, and the RPE-Brooks membrane complex. The external limiting membrane is formed by the apical processes of the Macular cells, while the ellipsoid zone is traditionally ascribed to the inner-outer segment or ISOS junction of photoreceptors, but recently is correlated with the photoreceptor inner segment of the ellipsoid. This organization of the retinal inner layers or DRIL is thought to represent damaged cells within the inner retinal layers, indicating a disruption in the normal visual pathway from the photoreceptors to the ganglion cells. DRIL is identified on OCT when there is disruption of the demarcating interface lines between all the layers from the ganglion cell layer to the outer nuclear layer. Eyes with DRIL have a worse baseline and final visual acuity despite anti-VEGF injections and have almost 8 times greater risk for poor visual recovery. In contrast, the resolution of DRIL has resulted in better visual outcomes. DRIL was better correlated with visual acuity when compared to glycemic status of the patient and the central subfield thickness. The OCT image shown here shows a combination presence and absence of DRIL and diabetic macular edema. Those on top, this one shows no DRIL and no diabetic macular edema, while this one has diabetic macular edema but with the inner layers with intact demarcation lines, while the row below shows to the left has DRIL and no DME, while to the right has both. Let us now go to the second OCT biomarker, which is the disruption of the external limiting membrane and of the ellipsoid zone. The ELM and the EZ disruption strongly correlates with baseline and final BCVA of patients with DME. At the same time, restoration of the ellipsoid zone was a requirement for good visual recovery in some studies. The photo shown in this slide demonstrates this biomarker. The photo above shows the presence of DME with large cystic spaces, and despite the presence of DME, the ellipsoid zone and the external limiting membrane are intact, giving the patient a BCVA of 2032. The photo below shows a 5-year after with extensive ELM and EZ disruption developing after a series of anti-VEGF injection. On this stage, the BCVA of the patient dropped to 2063. The third OCT biomarker is vitreomacular interface abnormalities. Here are photos of 2 eyes with vitreomacular interface abnormalities and concurrent DME. DME associated with vitreomacular interface abnormalities, notably epiretinal membrane or vitreomacular traction, has poorer visual outcomes, and VMIA has been observed in 7 to 16% of eyes with DME with an annual incidence of up to 4.5%. For VMA, the READ-3 trial showed that the eyes with VMA still had good response to anti-VEGF therapy, while the presence of posterior vitreous detachment has been associated with improved visual outcomes. It is also reported that DME was present in 55% of eyes with attached posterior hyaloid compared to only 20% of eyes with PVD. Also, there is 25% rate of spontaneous resolution in eyes with attached posterior hyaloid compared to a 55% resolution rate in the eyes with PVD. Although the OCT biomarkers are described as 3 distinct entities, all 3 can be present in a single patient. This case is my patient who presented initially with a cystoid macular edema but with a BCVA of 20/25. Note that the ELM and the ellipsoid zone are intact. After completing the loading dose of bevacizumab, she developed all 3 of the DME OCT biomarkers associated with poor visual outcomes. She has DRIL, the disruption of the ELM and the ellipsoid zone, and the presence of epiretinal membrane. She started with a BCVA of 20/25, and at this stage, the BCVA dropped to 2400. The next ancillary procedure that is being used in the management of DME is fundus fluorescein angiography. FA has been a valuable diagnostic tool in diabetic retinopathy for decades and is formally known as the essential component in the assessment of severity of the pathology and delineation and location of retinal blood flow alterations to allow appropriate and targeted laser therapy. However, there's currently only moderate consensus on the role of FA in the management of DME, as nowadays, some clinicians would base treatment decisions on the basis of OCT only. Nonetheless, FA remains the only commonly approved modality that can distinguish non-leaking from leaking microaneurysms, define clearly the presence of ELMA, and delineate areas of capillary non-perfusion and widening of the foveal avascular zone. With the advent of anti-VEGF therapies and the corresponding reduction in the need for laser, and the detailed morphological imaging possibilities with high-resolution OCT, questions have arisen on the need for conventional FA. However, standard spectral domain OCTs cannot identify foveal ischemia and widening of the FAZ, which are important prognostication factors of the outcome. This case presented here is a 57-year-old female, known type 2 diabetic for 8 years, with variable sugar control. The color fundus photo shows dot plot hemorrhages temporal to the macula, which shows as an area of black fluorescence on FA with adjacent microaneurysms. There's note of hard exudates in the supertemporal macula and temporal to the fovea, also with adjacent microaneurysms on FA. In the later phase of the study, there is hyperfluorescence within the macula with a petaloid pattern corresponding to the fovea that is usually associated with cystoid macular edema. Let us now move on to management. Management of DME can be achieved via a variety of ways, starting from addressing systemic issues, laser therapy, intravitreal injections of anti-VEGFs, or implantation of drug delivery devices, and finally, surgery. Generally, this chart shows the effects of the different treatment modalities in the management of DME. Let us begin the discussion on DME treatment with lasers. The ETDRS demonstrated superior visual outcomes with focal or grid laser for clinically significant macular edema compared with natural history. Lasers thus became the standard of care for 30 years. Treatments were repeated at 4-month intervals if CSME persisted, and if there are treatable lesions that are still untreated, if there are thickened and non-perfused retina that remain. The average patient received between 3 to 4 focal or grid laser treatments. It is important to note that though it is clinically effective, the ETDRS style of focal or grid laser photocoagulation for DME has potential side effects, including paracentral scotomas, subretinal fibrosis, and secondary choroidal neovascularization. This photo shows focal laser photocoagulations, which denoted by the green spots, are applied on the leaking microaneurysms of focal macular edema. While this photo shows grid laser photocoagulations around the fovea that are used to treat diffuse macular edema. The technique of focal or grid argon laser treatment has been modified over time. The most significant changes are embodied in the DRCR.net protocols that employ focal or grid photocoagulation. Rather than burns that can vary from 50 to 100 microns, most contemporary burns start at 50 and they are less intense. Yellow wavelength laser are also acceptable in addition to the green, but blue-green is not used because of concern of overabsorption by the macular luteal pigment. The usual settings for the focal or grid laser are as follows. The next modality of treatment for DME are corticosteroids. Steroids were first used to treat DME in 2001. Triamcinolone, dexamethasone, and fluocinolone have been used in many forms, including particulate suspension, viscoelastic mixtures, and slow solid-release devices. Many dosages and intervals between the triamcinolone injections have been tried. Although enthusiasm at first were high, Protocol B of the DRCR network showed that focal laser led to superior visual outcomes compared to triamcinolone. Since then, steroid therapy have taken a secondary role to that of anti-VEGF. Side effects are also commonplace, such as cataract in phakic eyes and elevation of IOP. Slowly dissolving intravitreal dexamethasone implants, shown to the left of the image, are effective in treating DME, although the visual acuity gains are generally less than that when compared to anti-VEGF injections. In a 3-year randomized controlled trial, MEAD, 0.7 mg dexamethasone implants was associated with 15-letter improvement in best-corrected visual acuity in 22.2% of patients compared to 12% in that of the sham group. Over the 3 years in phakic patients, 59.2% of eyes required cataract surgery, while 41.5% of eyes requires the use of ocular hypotensive therapy. The long-term visual outcome of intravitreal dexamethasone implant therapy correlates with a 3-month treatment response. The next available implant is intravitreal fluocinolone acetonide. Unlike the dexamethasone implant, these do not dissolve, and it also has its own study, known the FAME trial, where patients with persistent DME, despite macular laser, were randomized to low dose and high dose. That's 0.2 microgram and 0.5 microgram per day, or the third group is the sham treatment. The percentage of eyes gaining at least 15 ETDRS letters at 24 months was 28.7%, compared to 16.2 in the sham group. Cataract surgery was required in 74.9%, and glaucoma developed in 1.6% of eyes. It is not new to all of us that intravitreal anti-VEGF is now a mainstay in the treatment of DME. It has been proven time and again by various landmark studies that indeed anti-VEGF is effective in treating DME. Due to the sheer number of studies, I will not dwell in discussing each of them. Instead, I will present the data of our recent network meta-analysis by Vergelli and company done in 2018, where they reviewed 24 studies that included 6,007 participants with DME and moderate vision loss. Data were collected on the drugs of direct interest, which are namely aflibercept, bevacizumab, and ranibizumab. The others were labeled as index. The study showed that aflibercept, bevacizumab, and ranibizumab were all more effective than laser for improving vision by 3 or more lines after 1 year, with high certainty of evidence. Approximately 1 in 10 people improved vision with laser, and about 3 in 10 improved with anti-VEGF. On the average, there was no change in visual acuity with laser after 1 year, compared with a gain of 1 or 2 lines with anti-VEGF treatment. People receiving ranibizumab were less likely to gain 3 or more lines of VA at 1 year compared to that of aflibercept with moderate certainty of evidence. For every 1,000 people treated with aflibercept, there would be 92 fewer who would gain 3 or more lines of VA at 1 year if treated with ranibizumab. While ranibizumab and bevacizumab were comparable with respect to aflibercept and did not differ in terms of visual acuity of 3 or more lines of VA, central retinal thickness reduction favored ranibizumab, with an average of 29 microns reduction compared to baseline, with low level of evidence. The authors concluded that anti-VEGF drugs are effective at improving vision in people with DME, with 3 to 4 in every 10 people likely to experience an improvement of 3 or more lines of VA at 1 year. Aflibercept may confer some advantage over ranibizumab and bevacizumab in patients with diabetic macular edema at 1 year in visual and anatomic terms, but it is unclear whether this applies to the long term. There is a need for more evidence on the long-term comparative effects of these anti-VEGF agents. Right now, there are new key emerging drugs that are at different phases of clinical trials. Most of them offer lesser injections per year compared to those that are available currently in the market. The last treatment modality for DME is surgery. The idea that vitreomacular adhesion might promote DME arose from the observation that eyes with DME have a lower prevalence of posterior vitreous detachment compared to eyes without DME. The subsequent observation that resolution of DME could occur after PVD strengthened the plausibility of surgical induction of a vitreomacular separation might improve DME. With the advent of OCT, vitreomacular adhesion was shown to be a risk factor for the development of DME. While vitrectomy for diabetic macular edema was first reported in 1992. Since then, many small retrospective and prospective studies, case series, several small clinical trials were done, but there are no large multi-centered randomized control trials. Vitrectomy was introduced for eyes with a taut posterior hyaloid adherent to macula, often associated with shallow traction macular detachment, which had failed previous focal or grid laser. Later, it was explored as a therapy for eyes with an attached but non-thickened, non-taut posterior hyaloid, or for eyes with persistent macular edema despite previous focal laser or intravitreal triamcinolone injection, regardless of the status of the posterior hyaloid. Here are images. To the left is a 21-year-old woman with type 1 diabetes with PDR and center involving diabetic macular edema. Their best corrected visual acuity was 20/40 at the time. Because of documented poor adherence to scheduled clinic visits, vitrectomy rather than serial anti-VEGF injections was chosen. At the top, we see new vessels present on the disc and the mid-periphery of all quadrants with pre-retinal hemorrhage superiorly. FA shows leakage of the new vessels in the areas of capillary non-perfusion and in the mid-periphery. Speckle domain OCT shows center-involving intraretinal fluid and subfoveal fluid. The ellipsoid zone is intact as shown by the yellow arrow. Post-operative images of the same patient is shown to the right, following a single pre-operative bevacizumab injection to limit intraoperative bleeding, vitrectomy, ILM peeling, and panretinal photocoagulation were done. The new vessels have regressed, and 5 years later, the center-involving diabetic macular edema remains resolved with no subsequent treatments. The best corrected visual acuity was 20/25. After discussing diabetic macular edema in general, its accepted diagnostic and treatment modalities, let us now move on to a special topic of interest, which is cataract and diabetic macular edema. There are few studies that evaluate the relationship of the development of diabetic macular edema and cataract surgery. The European Society of Cataract and Refractive Surgeons conducted a study known as the PREMED study, or the prevention of macular edema after cataract surgery, recently. The study outcomes paved the way for the first evidence-based clinical guidelines to prevent cystoid macular edema after cataract surgery in both diabetic and non-diabetic patients. There are two arms to this study, namely PREMED 1 and PREMED 2. The first arm focused on the non-diabetic group, while the second arm focused on the diabetic group, which we will talk more about. We will reserve the first arm for another day in the interest of time. There were 213 participants in the diabetic arm. The diabetic patients were given bromfenac and dexamethasone eye drops and then divided into 4 groups. The control, which will only have the same eye drops, the subconjunctival triamcinolone group, the intravitreal bevacizumab group, and the group that will have both. The study showed significant effect of subconjunctival triamcinolone on post-operative macular thickness and volume. At 6 and 12 weeks post-operatively, the mean central subfield macular thickness was lower in patients who were treated with 40 milligrams of subconjunctival injection of triamcinolone compared to those who were not. This study, however, could not identify a significant effect of intravitreal bevacizumab on post-operative macular thickness. The study also could not identify significant interaction between bevacizumab and triamcinolone. None of the patients who received subconjunctival injection developed macular edema after surgery, according to the PREMED study definition of more than 10% increase in baseline central subfield thickness or more, including 2 patients with already cystic changes on baseline SD-OCT. The incidence of cystoid macular edema was comparable in patients who received intravitreal bevacizumab compared to those who did not. No statistically significant difference between treatment groups, however, with respect to visual acuity at 6 and 12 weeks post-operatively. It's good to note that IOP was also significantly higher in patients who received subconjunctival triamcinolone compared to the others. Resection of a triamcinolone depot was performed at 12 weeks in 1 patient who developed IOP of 42 mm mercury, uncontrollable with topical brimonidine, dorzolamide, and timolol. Within 2 days after resection, the IOP decreased to 24. This slide showed the central subfield mean macular thickness observed with 95% confidence interval as shown from baseline at 6 weeks and 12 weeks. And this one, the intraocular pressure at baseline at 6 weeks and 12 weeks showing a slight increase. In conclusion, the results of the ESCRS PREMED study provide compelling evidence that a single subconjunctival injection with 40 milligrams of triamcinolone effectively prevents the development of CME within 12 weeks after cataract surgery in diabetic patients. However, the risk of developing macular edema after cataract surgery should be carefully weighed against the risk of developing treatment-related complications such as increased IOP. The results of this study are promising. However, further research should explore the optimal route and dosage of corticosteroid and its long-term benefit. Intravitreal bevacizumab had no significant effect on the postoperative visual acuity or macular thickness in the investigated diabetic population. The efficacy of both treatments should be further investigated in patients with preoperative diabetic retinopathy or diabetic macular edema. As we now close to the end of this lecture, here are the learning points that we must remember. Diabetic macular edema commonly leads to impairment of visual acuity in patients with NPDR and is more prevalent in patients with type 2 DM. Diabetic macular edema may develop at any stage of DR, but more frequently in those with severe retinopathy. OCT plays a major role in identifying new biomarkers in visual prognostication. Focal and grid macular laser are effective in decreasing macular thickness but has minimal effect on visual improvement. Be cautioned of the possible adverse effects. Anti-VEGF is a mainstay in the treatment of DME, and the ESCRS PREMED 2 study reported that DME happens at the 6 to 12 week postoperatively following cataract surgery, and that it is successfully prevented by subconjunctival triamcinolone. However, one should weigh the risk of IOP elevation. Here are my references. Thank you.